Kānuita mihi mahana kia koutou katoa. Welcome everybody to another lunchtime webinar from Mobile Health. My name is Pauline Proud and I'm very pleased to introduce you to Shyama Abraham today, who's your presenter. And Shyama has worked at the county's Manukau DHB for nearly 20 years, and most of that time she's been in the respiratory area. Shyama has worked in the adult outpatient respiratory service as a clinical nurse specialist for over 12 years now. And her main area of work is in sleep. And she works in the localities such as Mangere and Otara. And Shyama's clinic is usually a split clinic with a few new patients to the service who need a full assessment for probable sleep disordered breathing, as well as follow-ups for those who are already established on treatment. And I know her team is very busy. And Shyama's talking to you today about obstructive sleep apnea, symptoms, diagnosis and treatment, and alternate treatments for mild to moderate sleep apnea. Welcome, Shyama.
Thank you, Pauline. Hi, everyone. Even though I can't see you, you're all imaginary to me. So I hope you enjoy my presentation. I'm doing the presentation for sleep apnea, as you know, and I've put up some nice, interesting pictures of some machines in my presentation there for you to have a look. Some of these date back to very, very olden days, and when we first started the sleep service, to now some of the very brand new sort of machines, which is the one on the top left-hand, right-hand sort of corner, the dark black box. That's our newest machine at the moment. So I'm going to take you through to the next slide. Sorry. Just talking about what happens when you don't have a good sleep. I think that's a very good start. If you need to know what happens with bad sleep, you need to know what happens with good sleep as well. You need to know both. So lack of good sleep, as we all know, can lead to lots of chronic health problems such as obesity, diabetes, cardiovascular diseases. It also puts you at a much higher risk of alcohol and drug dependence issues. You're at a much higher risk of having a car accident if you were to fall asleep because you haven't had a good night's sleep. Sometimes shift work and things also make you tired. So driving back home after a night shift puts you at a higher risk of car accidents. Making mistakes at work. So if you can't focus because you haven't had such a good night's sleep or you didn't sleep long enough, stress also makes it worse. But you make a lot of mistakes, and some of these mistakes can be small, some of these mistakes can be quite big. There's also problems with relationships that people have due to a lack of sex drive, and I'm sure you will hear most people talk about it. We see a lot of people in our clinic who have been referred from the sexual health clinics from the hospitals, in other hospitals. So before we get into the actual sleep apnea side of things, most of our referrals coming in will generally say patient is tired, patient is sleepy, and it gives you a scoring, which I have got a copy of at the end just to show you what that scoring system is like. But it'll say patient is tired, patient is sleepy, please have a look at the patient. And before we actually get into the details of the assessment that we do in clinic, we just like to go through a few things in our head and see whether is that something that patient fits into the criteria for rather than just sleep apnea. So there's a lot of things to think about, and I won't go into the details of all of them, but tiredness and sleepiness can be caused by a lot of other issues. There's things like restless leg syndrome, there's narcolepsy, there's hypothyroidism, hyperthyroidism, and generally the GPs would check for thyroid and do blood tests before they send them to us, which is a good thing. There's also rheumatoid arthritis, poor sleep hygiene, shift work, anemia, circadian rhythm disorder, REM behavior, pain. Pain is a big one too, because mostly adults or older people have lots of issues with pain. Generally, young, healthy people also have issues with pain if they've been in an accident, they're on ACC, all of a sudden they find that they can't sleep because they've got too much pain and they get referred into clinic. So these are some of the differentials for tiredness and sleepiness, not just sleep apnea alone. And talking to a lot of people, majority of people, the minute they hear tiredness and sleepiness, they think sleep apnea these days. Sleep apnea was not very well known before, but it's very well known these days. And I think that's probably why we see a lot of referrals coming through compared to what we had before. In counties, we have close to 8,000 people just in South Auckland that we look after who have sleep apnea. It's a very common sleep disorder, and it's associated, as in my first slide there, increased rate of motor vehicle accidents, cerebrovascular disease, atrial fibrillation, lots of daytime sleepiness, and it's very common, about 4% male and 2% female. So what is sleep apnea? And I've put a little slide there to explain things a little bit better. It's very basic. It's not going into very much detail, but it's a very basic explanation that we use even in the clinic in the form of pictures that we use to explain to our patients. So the first one, picture up on the top, that's normal breathing. And you can see that the space there is nice and open. If you can see my case, I'm not quite sure if you can or not, but basically the airway passage here is nice and big, and the air can just flow past. There's no blockages of any sort there. But when it comes to people who snore, there's a partial obstruction of the airway, and you can see this part here. It's not very wide, it's not very open. If you compare the top one to the bottom one, there's not much space there. And that's because the muscles have relaxed. There's nothing that a person can do to stop this from happening because it's all controlled by your brain, as we know. With a complete obstruction, so the third picture down there, you can see it's completely blocked away and there is no air that is able to go past. If there is no air able to go past, this is where most of the people will say, I get told that I stop breathing at times, or my wife nudges me when I sleep to wake me up. And that's very common. Sometimes people say, my family tell me that I snore and I stop breathing. And this is when the GP sends a referral to us. So sleep apnea is caused by the muscles in the back of your throat relaxing during sleep. These muscles support your tongue, your tonsils, and your soft palate. And when we talk about diagnosing, we usually say apnea and hypopnea, as in the picture. And apnea is when there's a total blockage of the throat and it lasts for more than 10 seconds. A hypopnea is a partial blockage. So there's a difference between the two. Apnea is a total blockage. Hypopnea is a partial blockage. The symptoms that most of the people get when they have sleep apnea is things like snoring. They can't concentrate. They have a lack of concentration. This is where they might report falling asleep when they are in meetings, or if they're sitting there doing nothing at their table, their desk, sometimes even watching TV, that fall asleep. Headaches in the morning when they wake up, feeling quite angry during the day, and that could be because they have not slept well and the sleep has not been a good quality sleep. Going to the toilet too many times in the night, that's another one. So that's similar symptom to diabetes. However, if it's sleep apnea, it will go away with the treatment. If it's related to something like diabetes, it will remain there even despite the patient being treated for their sleep apnea. Feeling tired, that's the other symptom, and poor memory, they can't remember things. These are just symptoms. Be mindful that not everybody has got the same symptoms. Sometimes people have only one or two symptoms and they don't have all of the symptoms. And we need to treat everybody differently as to what their symptoms are. Some of the causes of sleep apnea, the major cause is weight or weight gain. If people gain a lot of weight, it can provide excess fatty tissue into the neck and the throat, and that's where they can have airflow obstruction. Weight is not the only factor, though. Sometimes people who are very, very skinny, They can also have sleep apnea. Now, that's a genetic reason for having sleep apnea. It's because the back of your airway or throat doesn't have enough space. And that's how your bones are made. So you can't do anything much about that. So not necessarily do you have to be overweight to have sleep apnea. It can be an overweight person's problem, but it can also be a slim person's problem as well. Age can also play a part. So the older you get, the more relaxed your muscles get. And sometimes with age, some people start to see the symptoms of sleep apnea becoming more apparent rather than when they were younger. So they might say something like, when I was younger, I didn't have any problems, even though I snored. But as I get older, I am feeling tired, I'm feeling sleepy, and my weight has not changed much. Enlarged tonsils and adenoids. We check for these in clinic, and I'm sure the GPs also check for these in the clinic before they send the referral through. So if they have very enlarged tonsils, very large adenoids, sometimes a referral to somewhere like an ENT service helps. If the tonsils are removed, the adenoids are removed, it can sometimes cure their sleep apnea. So enlarged tonsil and adenoids should be checked. Alcohol, as we all know, if you drink lots of alcohol, it relaxes the muscles in your body, including your throat muscles, and therefore it predisposes you more to snoring and sleeping longer and waking up feeling unrefreshed. Smoking damages the lung, as we all know, and sometimes the inflammation and the retention of the fluid in the upper airways can sometimes impede the airflow. So when you're sleeping, you don't have such a good night's sleep. So smoking can irritate the lungs, and it can sometimes cause some of the symptoms of sleep apnea. When we're talking generally, I'm sure we all talk about giving up smoking, quitting cigarettes, giving up alcohol, and making lifestyle changes. Some of the risks that are associated with sleep apnea are things like high blood pressure. Sometimes we get referrals that come from the GP because the patient has high blood pressure. They are already on 2 or 3 types of medications, and the GP has problems controlling the blood pressure. Sometimes we get referrals coming from the cardiology doctors because they have an irregular heart rhythm, or they've had a previous stroke, etc., and they think that the sleep apnea might be a probable cause for their problem, and treating their sleep apnea could actually help treat some of their heart issues as well. Diabetes, and obviously high risk of falling asleep while driving. So these are people who can be referred from either their workplace directly to the sleep service for investigation of sleep apnea because they were noted to have fallen asleep during their meal breaks or at the machine, or something's happened at their workplace, maybe a workplace accident of any sort, that they now have to be investigated for sleep apnea. Some people get referred from the GP if they've had an incident where they have fallen asleep and they've caused an accident on the road. So they have a court case and they have police involvement because of falling asleep. The other one is indigestion and acid reflux. So some people, I've heard of lots of people in the clinic, some people say, I wake up and I've got vomit in my mouth, which is quite unusual. Some people will say, I wake up with acid reflux and heartburn, mostly early hours of the morning or even in the middle of the night. These are generally because they've had a big meal and they've gone to sleep. But it can also happen even though they have not had big meals, and that's just the reflux from the apnea, which is where they suck the contents of their stomach up and then back down again if they were sleeping during one of those apneas. This is just an example of a very basic sleep study. So there's lots of different types of sleep studies. There's like a level 1, level 2, level 3, level 4 sleep studies. Level 1 and level 2 sleep studies are basically PSG or polysomnography sort of studies. They're the highest level, gold standard sort of diagnostic studies that we get. However, counties where I work, we don't have a PSG lab, so we rely mainly on the level 4 and level 3 sleep studies. We've probably by next year would be able to do some level 2 polysomnography sleep studies, which are basically just unsupervised polysomnography studies. Polysomnographies is where somebody goes into hospital and they basically sleep in the hospital overnight, and they get hooked up with a lot of leads on their heads, their arms, their legs, a few on their chest, and it basically just gives lots of readings on what's happening with them. With this one here, it's a level 4, so it's very basic, but it gives you good information, and that's what we want. We just want to know whether this person has got sleep apnea or they don't have sleep apnea. The numbers in itself don't make that much of a difference as long as they give us an idea of where this person falls. So when we have sleep apnea diagnosis, we usually grade people into mild, moderate, or severe. Mild is basically anybody who falls into a apnea, hypopnea group of between 5 and 15. Less than 5 is normal. 5 to 15, it could be mild sleep apnea. They not necessarily have to be treated on treatment. It depends on how tired, how sleepy they are. And if they want to be treated, then they can say, hey, look, I want to be treated and just see if I feel any better, but they don't have to be treated for their sleep apnea. They can go for other alternate treatments for sleep apnea, which I will be discussing later on in the presentation. With the moderate group, that's anybody diagnosed with sleep apnea between 15 up to 30, and that's the middle group. Anything past 30 blockages an hour, it puts them into the severe group. So if I were to get you to look at the overnight oximetry that we have in front of you, if you can see my case, I'm pointing at ODI. ODI is basically how many times this person has had an apnea or hypopnea, and that's the criteria that I was talking about. So ODI, this person has 28.6 blockages per hour, so they fall into the moderate sleep apnea group. If you look at the lowest oxygen saturation up here, it's about 71%. This can sometimes be unreliable if there is a lot of artifacts, which are some of these things where the oxygen saturation drops too low. And the mean is 94.4. So we all, majority of us, I assume our nurses in the presentation, we all know that if the mean saturations are above 90, it's a good thing. If they're below 90, it's not such a good thing. And you may actually get oxygen given to you at home if your oxygen levels are less than 90%. So mainly the criteria is around 85, 84 or below of oxygen saturations during the daytime. So in the night, if they are dropping the oxygen down to something like 70, it's too low, but nobody's watching them when they sleep. If you look at the graph itself, the blue graph is the oxygen saturations itself. All of these ones, they look kind of normal, but as they go down, you can see some of the drops going down, and these would be those hypopneas, the partial blockages, which don't let the oxygen level drop down too low. But if you look at some of these big ones here, these are where the oxygen levels are dropping down, 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 and then up again, and then down, and then up again. And it just keeps happening one after the other throughout the night. Then it becomes better, then it becomes worse, then it becomes better, then it becomes worse. If we see something like this, which is where the oxygen levels are dropping down and they're dropping away in clusters, it could mean that this person was sleeping on their back, or it could mean that they were going into their REM stage of sleep, which is where they go into a very deep stage of sleep, and that's where the oxygen levels are dropping more. If you look at the green one just down below, the green one shows you their heart rate. So when we talked about the risks in the previous slide, we talked about high blood pressure issues, and this is where you can see from this study, if the oxygen level is good, this one is a good one to look at. If the oxygen levels are nice and good, they're in the normal range, you look right underneath, and the heart rate is also nice and normal. There's no spikes in there. But when the oxygen level drops throughout the night, the heart rate also drops throughout the night. And the heart rate can go up, it can go down, it can go up, it can go down, it can go either way. But that's very unstable with lots of spikes going on, and it's not normal for people to have heart rates of 98 and 100 when they are sleeping. It should be within the normal ranges of 60 and 80 for most people anyway. If they take blood pressure tablets, sometimes it keeps the heart rate lower. However, the graph looks very thick if you're looking at the graph. Don't worry about the brown line downstairs and these ones. I'm not going to talk about them. They're just computer-generated graphs. It doesn't affect the treatment or their diagnosis in any way. This is a copy of a level 3 sleep study, which is called an Embletter. And this is a bit more informative. It gives us a bit more information of what happened to the patient when they were sleeping. So the top line there tells us whether they were sleeping on their back, they were on their right, they were on their left, what time did they start the machine, what time did they stop the machine. It also gives us their oxygen levels as the previous graph, gives us the heart rate as the previous graph. And then down below, it actually gives you the apnea and the hypopnea, and it separates the two out for you. So you can see them very clearly. The green ones are the apneas, which are the complete blockages of 10 seconds or more. And the one down below is the partial blockages, which are, it could be anything above 10 seconds or longer, but these are partial blockages. And you can see there's a lot of it in different colors, which makes it easier for you to see. If you go to the gold standard testing, which is the polysomnography or PSG, as we call it for short, it gives you similar sort of numbers, and PSG can be done purely as a diagnostic study overnight just to see what the patient is doing in the night, or it could be done as a split night study. Now, I've got a copy of the split night study in this slide here. So if you look onto the left-hand side of the slide, it's got the oxygen saturation, it's got the heart rate in brown, and then down below, it's got all of the apneas and the hypopneas. The obstructions on these ones, or the apneas, are in black down the bottom, and the hypopneas are kind of yellow or green, whichever color that is. And it's split in half, so it's a split night study, which means they were only looking at this person for at least a couple of hours before they decided that they were severe enough that they wanted to start them on a CPAP. And you can see that they started them on the CPAP up on the top line where my pointer is, saying pressure. So they start off very low, and then through the night, they keep adjusting it little by little until they get to a point where they think, oh, no, we've adjusted it enough. So that would be towards the end of the night. If you compare the end of the night results, see the oxygen saturations have settled quite a lot compared to what it was at the beginning of the night. Heart rate at the beginning of the heart study was very irregular, and towards the end, it looks a little bit more settled. There's no obstructions towards the early hours of the morning once they've been started on treatment. And the hypopneas have also reduced. The hypopneas never completely go away because if with any treatment, it takes time for your body to get used to it. It takes time for inflammation to go down. So with snoring, there's always inflammation of the throat and the breathing passages. So with the inflammation, it wouldn't reduce just overnight. So you will always have a few hypopneas. However, they will reduce in time if you give it at least a week or two. With the treatment options, basically, there's a lot of things that are there in terms of options. So CPAP, it's a gold standard treatment for sleep apnea. We use CPAP in the majority of the places in DHBs because they are funded by the government. It does not cost the patient any money to buy the CPAP unless they are a private sleep service. If it's a private sleep service, they will sell you the CPAP, and every time they do follow-ups or they check anything for you, you will actually be charged. In the public system, the majority of the public systems that I know of, like Auckland, counties, not sure Waikato, we all provide the CPAP machine to the patient, and we give them a set of mask and consumable for the first time, which they do not need to replace if they're looking after everything for at least a year or more. With the AutoSet BiPAP machines, I'm not sure if you guys know much about them, but they're basically just another form of a machine. A CPAP is a continuous, a fixed pressure machine that we use to treat sleep apnea with. It basically does not change the flow of the air going up. It stays at the one pressure that we set the machine to. If you think about it, if this was your airway, then you want to provide a splint, and this is your CPAP machine. You put the CPAP machine in your airway, and it acts like a splint where you can't drop your breathing passage down, you can't block your airway when you sleep, and it keeps the airway open throughout the whole night. That's the picture of the CPAP there. It's a fixed pressure machine, splinting the airway there when you sleep. If you sleep without the CPAP, it doesn't give you any treatment, so you still continue to stop breathing. With the AutoSet machine, it's similar to a CPAP, however, it's variable pressures. So there's two different set pressures on this machine. Some people find it more comfortable to use the AutoSet because it starts off at a very low pressure, and in the night, it kind of senses how the breathing is for the patient, and it'll self-adjust up and down depending on the breathing for the patient. So it's got a minimum pressure setting, and it's got a maximum pressure setting. Now, the pressure settings come from the sleep clinic. They're kind of like a prescription. So unfortunately, GPs can't change it, and even the nurses in the normal parts of the hospital can't change the pressure setting, not unless it's been okayed by the sleep clinic. And usually the settings are locked in the clinician setting mode. So not many people know how to get into the clinician mode to check. With the BiPAP, BiPAP machines are generally used for type 2 respiratory failure patients who have carbon dioxide retention, but it can also be used for extremely overweight sleep apnea patients who have OHS, which we call obesity-related hypoventilation syndrome. And it's basically where the CPAP itself doesn't work for these people. The pressures are not high enough. CPAPs can only go up to a maximum of 20 centimeters, whereas BiPAPs can go a little bit higher. And BiPAPs, similar to AutoSets, have two different pressures. Sometimes it's a much better way of treating the patient compared to a CPAP machine on its own. So which treatment the patient goes ahead with will depend on the clinician. And in our DHB, mostly we start everybody on a CPAP or an AutoSet. And then later on, when they have a repeat sleep study, they have follow-ups. If they're not responding to the treatment with the CPAP or AutoSet, that's when they get put onto a bi-level machine. So that's a clinician's decision if they want to transition them to a much more sophisticated machine. And then there's mandibular advancement devices or tongue stabilizing devices, which look like these. So they kind of look like mouth guards, which you wear at night. And it depends on different people. Not everybody likes the mandibular advancement splint or wearing the mandibular advancement splint or the tongue stabilizing device. I've got a picture of it here. In my whole 14 years, I don't think I've ever come across anybody who has used a tongue stabilizing device, but I've come across a few people who use mandibular advancement splints. And they're kind of like rugby mouth guards, which you can adjust. So you sleep with it on and it doesn't let you snore, it doesn't let you stop breathing. From all of the research that has been done around mandibular advancement splints, if you buy them cheap from places like Harvey Norman, No Leaving, you're not guaranteed that it will give you good treatment. And just out of curiosity, we also did a couple of patients' sleep study tests while they had the mandibular advancement splints, and it didn't show any difference in terms of treatment, but they did report that they were feeling much better compared to the CPAP treatment they were having before. So mandibular advancement splints, they may or may not work. We recommend that they go and see a proper orthodontist if they did want to go ahead with mandibular advancement splint, because an orthodontist will make a custom guard for you, which they will monitor and they will update as time goes on. Because with wear and tear, they do need to be readjusted. They will probably need to be replaced if something broke. But at least you have got the support of an orthodontist with the mandibular advancement splint, so you know that it is going to give you good treatment. There's also surgery. So many people come and ask us, why can't you just do surgery for sleep apnea? Surgery can help mild or moderate sleep apnea patients, but it generally may not help the severe sleep apnea patients. And you can see from the picture that I've put up, they actually chop all of these bits off and they make your airway nice and big, but it's not guaranteed that you're not going to have sleep apnea. You may still have residual sleep apnea even after going through surgery. And we have got a handful of people who have actually gone back on the CPAP machine after they've had their surgery. The one thing that I didn't say for mandibular advancement splint is that you need to have your full set of dentures or teeth. If you have got lots of missing teeth or gaps in your teeth, then it may not be the bestest of the treatment for you. And then towards the end there, I've put weight loss, which is a long-term treatment option for sleep apnea. Some people have managed to come off the CPAP machine if they lost weight. Weight loss is not very easy to do, and some people struggle with losing weight. Some people have got other issues, such as ladies, they might be going through menopause, or they might have infertility issues, hormone issues, that doesn't allow them to lose the weight very easily. So weight loss, we recommend weight loss for all our patients long term, but it's not a quick fix for the sleep apnea. So with CPAP treatment, very important to remember that it's a treatment only. It does not cure the sleep apnea for patients. So when we see them in clinic, we actually remind them of this, and we say to them that they need to remember this because they need to use the CPAP machine every single day, every time they sleep. There's no time limits on when they can use the machine. They can use it in the day, in the afternoon, 2 hours, 3 hours, 4 hours, depending on how long they're sleeping for. If they're shift workers, they might want to sleep 2 hours or 3 hours and then go back and have another 1 or 2 hours of sleep. So that's how they should. Minimum treatment time on the machines are usually 4 to 5 hours in total over a 24-hour period. So some times we get asked, how do you know somebody's using the machine or somebody's not using the machine? So once we've given somebody a machine for their treatment, these days the machines are way more advanced. Before, we only used to rely on the hour meter or the information that we could see on the machine itself, but things have changed over time quite a lot. Now we have inbuilt modems into these machines which submit the data into the cloud, and we can download the reports from the cloud system and check whether the patient is using the machine, they're not using the machine, or how long they are using the machines for. We can also adjust their treatment remotely. So it's a good thing for the patients because they don't need to come into the clinic anymore. We used to bring them into clinic, and if they were not using the machine, then bring them back again, and sometimes they'd keep coming back to us 4 or 5 times. And that can be very costly because they have to take time off work to come into clinic. They will not be paid. Sometimes the employers don't want to give them time off work, but we needed to see them to be able to see whether they are using their machine, are they getting good treatment, or are they not getting good treatment. If we wanted to adjust something, we had to have them physically there to adjust any of the settings on the machine. Now we can do everything remotely. So I've got a picture or an example of a download up there for you. If you look at this report, it basically tells us the pressure setting for this patient. So they've got a minimum set pressure, a maximum set pressure. It tells us what type of machine it is. It tells us the humidity, which is how hot or how cold the air is that's coming out for the patient. And if it's a comfort setting, so the patients usually self-adjust that themselves. using the buttons on their machine, but at least we can see what the setting is. So if there were to ring us with problems, we can usually look at the report and troubleshoot from the report itself. It gives us an average usage. So this is the average hours that this patient is using the machine for, and this is a very good compliant patient, using it for close to 6 hours and 47 minutes on average. If you look at the report, this is a 60-day report, so for the last 2 months, and then it gives you the total report, which is from the date that this person had this particular machine given to them. So it's got the full report, and then it's got the 60-day report. And it tells you how many days they've used the machine, how many days they have missed the machine, what is their average when they are using the machine, and what is their overall average. This one here, which is the AHI, is the treatment for this patient. So in the diagnostic part, we could have seen that somebody stops breathing 40 times every hour, and that's a severe sleep apnea diagnosis from that report. Once they go on a CPAP, that number should go down. So if that number is less than 5, it shows good treatment. Even if it is up to 6 or 7, we're generally not too fussed about it, as long as the patient reports feeling well, getting a good night's sleep, they're not waking up with the headaches or any of their symptoms that they had before they went on the CPAP machine. So the AHI on the machine tells us whether the pressure that we have given that patient on the machine is a good pressure or not. And this is where we can adjust the pressure if it still shows a lot of blockages happening in the night, which would be that they're not getting good treatment. We can also check whether they are fitting their mask correctly or not. So mask leak down here, it gives us a number, and up to a 24 is a normal leak level for any machine, any mask that they might have. But if we see something like 80, 90, or even 100 or more liters per minute leak, then we know that this patient would be having problems with having lots of noise coming out of the machine, as they normally say, or the water blowing into their face, or waking up with headaches in the morning. So depending on their symptom when they phone us, we would look and check all of the reports to see what makes sense. Are they leaking a lot of air, or is it the machine making a lot of sound? So mask fitting is very important, because with the CPAP, you want to have a complete seal on your face so that it can push the breathing passage open. And if you don't have a good seal on your face, then the air can escape from the sides of the mask, which then reduces your treatment pressure down. And so they will have a lot of blockages up here despite being on treatment. If I go to the next page, it tells us a summary of everything all in one. It tells us how good the treatment is for this patient. The next one here shows us the pressure setting and what the fluctuation is. So this is the minimum set pressure line. That's the maximum set pressure line. And this patient is generally within that pressure setting, because the bars are dark blue and within or underneath the other top line. The light blue is basically just some of the leaks that are happening, which might increase the pressure up a little. So the bottom one here is the system leak, and that's the leak coming out of that patient's mask fitting during the night when they are using the machine. The orange bars that you see is basically too much of the air escaping out of the mask, and it's reduced the treatment time for this patient. So that's why if you have lots of oranges, it's not a good report. If you have lots of nice blue lines, low lines up to about 40, 45, it's a good mask fitting. It also tells us when they start and when they stop using the machine, so we can pick up some night shift workers or people who have really bad sleep hygiene issues. You can see from this, because they will not have a regular sleep pattern, and they will be going to bed at odd times during the night. Sometimes they'll start the machine here, sometimes they'll start the machine way towards the morning. And if the usage is very little over here, it could mean that they've just forgotten to put their machines on. So it gives us a good idea as to what might be happening with the patient. If there's a lot of breaks, so some of the lines, if you see, they have a little tiny break in there. If there's lots and lots of breaks, it means that this person is waking up too many times in the night and removing the mask. And so you could just discuss why that might be, what's happening. And it could be just that they have a little baby in the room, and every time the baby cries, they have to throw the mask away and attend to the baby and come back to the mask and the machine again. So very important to actually get feedback and talk to your patient about what's happening. Then the very last page, it tells us all of the same information, but in a graph sort of form. And I find that the patients actually like this graph format a little bit more easier, because then they can see that, the mask is leaking here and it's got a good fit here, then it's leaking over here. And when the mask is leaking, then they are waking up too many times up on the top. It just makes it more visible for them to see their report when they are in clinic. Makes it much easier for them to understand their report as well when we go through the reports with them. So nursing management, short-term and long-term, as I've mentioned before, they need to fully understand the reason why they have a CPAP machine. They need to understand the benefits of what the machine is going to do for them. So it's going to give them a better night's sleep. They won't snore. They won't stop breathing. They should wake up feeling nice and energetic the next morning. They shouldn't feel tired or shouldn't feel sleepy during the day. And those are the benefits that they need to look at. So we generally say to them, have a look at what your symptoms were before and compare it to after you have started the CPAP machine, and tell us what has changed, if anything has changed. If they say, no, I'm using it, but I don't feel any benefits after using the machine, that's when we actually need to find out if there's any other reasons for their tiredness or sleepiness that is not being fixed by the CPAP machine. Because it may be that they have mild sleep apnea, but they have something else going on in the background. They all are encouraged to use the machine for longer than 5 hours. Good mask fitting, as I mentioned before, because of the report and how the treatment actually works. And we are always there to help them with troubleshooting. For private hospital rest home patients, I know some of you are from that side. So if you have a CPAP machine, as I mentioned before, you can't change any of the clinician settings on the machine. So you can't change the air pressure or the treatment pressure or the settings, the comfort settings for the patient. But you can do the general normal everyday care for that patient. So if you have the bowl, as I've got in that picture, all CPAP machines come with a humidifier bowl, and they all need to have fresh warm water from the tap before they start using the machine. Now, the reason I say warm water is because sometimes some people have problems with getting a blocked nose or sinus in the night when they go into bed. So if you give them a cold hit of air coming into their nose from their CPAP, it can instantly block their sinuses and they won't be able to breathe, which means they will not be able to use their CPAP machine. The machine will heat up the water itself anyway, but it takes about 10 or 15 minutes for the water to heat up. So it's just better to start off with warm water. It's just a nice tip that we give to every one of our patients when we start them on CPAP. So if you start with warm water, the machine can actually maintain that warmth depending on your humidity setting from the machine. There's lots of different types of CPAP as for my initial slide. So unfortunately, I haven't put anything up for anyone to see if you can change the settings and how to change the setting, but you're more than welcome to contact us and we will tell you how or what to look for. Patients usually get given booklets in their bags, and that will have the information there. Internet Google is a wonderful place. You can find all sorts of information there about the machines too. If you're filling it up with the water, you must also empty it the next morning. Please don't let your patients just leave the water in the machine day after day after day and just keep topping it up. It makes the water slimy. It sometimes grows brown, black mold into the bowl. And if you imagine whatever is growing in those bowls, as in mold, etc., your patient is actually breathing it all because it's all going through the mask, the bowl, and the machine into their lungs. So there is chances of them getting sick or unwell or getting infections, etc., because they are not cleaning their equipment. Never ever move the machine with water in it. We've got a few people who come from private hospitals and rest homes, and sometimes they haven't had the water chamber emptied. So if you are taking your patient anywhere, or you are moving them from one place to another, please make sure that you have emptied the water from the Cpap machine. The machines are very expensive. If someone was to go and buy it, it would be a cost of at least $2,000 to $3,000 for you to buy the whole package. So it's very expensive and it needs to be looked after. It's also an electronic equipment, so just for electrical safety reasons as well, you shouldn't have the water sitting into the machine, and don't move the machine if it's got the water in it. Washing the mask and the cushion. So we usually say just use any dishwashing liquid, any hand soap that you might have access to in the hospitals or the private hospital rest home. Just use that, wash the mask, just gentle, nice rub with the back of your hands, rinse it in cold water or warm water every second or third day at least minimum. And that would make sure that your mask and your machine is nice and clean and the patient can have a good fit. If the mask cushion is oily, it's not clean, you can get lots of pimples, skin rashes, the mask will leak, it'll slip in the night, it can sometimes sound whistly, so you get a lot of problems with the mask and the machine. And when you're fitting the mask, if your patient cannot do it themselves, then if you're doing it for them, just make sure that you're fitting the mask tighter on the bottom part. So if you have a full mask, it covers the top of your nose up to just the bottom of your chin. And when you have the mask like that, just tighten the straps here so it's not easy to move up, and it's firm. If it's firm, you will not get so many problems with mask leak. But if the top one is too loose, just make sure it's touching the forehead. Don't make it extremely tight, otherwise your patient will get a headache in the morning when they wake up. We don't recommend using wipes to clean your mask or your machine, a humidifier bowl, etc., because the alcohol in some of those cleaning wipes can sometimes damage the silicone in the mask. So it's better to use soap and water. The hose, you can rinse it once every week or even a fortnight. If patients are in their own home, private hospitals, they can just take it into the shower and just give it a rinse in the shower and then hang it up during the daytime to dry out. They shouldn't be put outside in the sun, otherwise they will crack. And the rest of the mask and everything can be washed, like the frames and the headgear that they have on their head could be just washed once a month. If they count as medical patients, we have a booklet that we give, and I'm sure all sleep services give them a booklet. We are the only ones who have a walk-in clinic that has changed since COVID, though it's still called a walk-in clinic, but they do have to have an appointment to come and see us. It's generally that they can come and see us between a certain time frame in the mornings, which is 9 o'clock to 12 o'clock. There's no times booked for them. They just come anytime between 9 and 12 to get their parts replaced or to see us if they have any problems with their mask or machine. For inpatients, we still don't provide any urgent service to the inpatients that we have in the hospital, but we will see them within 24 hours if they are referred to us. For anybody who doesn't live in our area, and I'm sure it's the same for any other sleep service, we do need to have a referral sent to us to be able to see these people. And that's because of the funding issue. If we are seeing them and giving them parts and they are not known to us or they don't live in our area, we unfortunately cannot give them the parts. If we do give them the parts, we will not be paid back for any of it. So it's kind of costing us as a service to provide parts for people that we don't know. If they are referred to us, the wait time can be a maximum of 120 days, but it can be a lot less if they already have a machine and they already have parts, etc. So everybody's different in the way they get treated. For the new patients that are coming into our service, as I said, a referral is needed because then it's graded to either a quicker pathway if they are already on a machine or the standard pathway if they are not known to us and they have not got the diagnosis of sleep apnea. So they usually get an overnight oximetry test, which is the level 4 test I showed you previous slide. And then that slide is, that test is also regraded again. If they have severe sleep apnea on the test results, they get seen a lot quicker by the clinical nurse specialists, which is one of me, and I've got another 2 ladies who actually help me with that. So there's all 3 of us who have got the training from the doctors, and we can do the full assessments for sleep apnea. We then go and discuss our cases with the doctor that is assigned to us. All 3 of us have a different supervisor that have been assigned, and then we would go and discuss the case with them if it's a complicated case. But at least the patient has a much faster way of getting their CPAP machine. Then there's the clinic follow-up, and as I mentioned, it can be changed later on depending on the benefits that the patient is getting or not getting. The ESS, I've had people ask me what ESS is before. So the GPs have an e-referral system, and sometimes they have got ESS built into it, and sometimes they don't have ESS built into it, but they do it. ESS is basically an Epworth sleepiness score, and it's asking the patient a few questions in a certain situation and asking them how tired or sleepy they would be. So, for example, on this top one here, if they are sitting and reading, what are the chances of them falling off to sleep? Never, slight, moderate, high, and you put your numbers down there for each of the situation. The higher the score, the sleepier the patient is. And all of the referrals that we get, they all have this attached to the referral, just to give us an idea of how tired or how sleepy this patient is. There's also the question about driving. So are they sleepy drivers? If they keep falling asleep in traffic lights, they've got a history of having a car accident, their referral would be seen much quicker compared to somebody who doesn't have any tiredness or sleepiness when they're driving. Before they get sent to us, it's always a good idea that some basic things are looked at. So that's things like sleep hygiene. Do they have a sleep schedule? If they do any regular exercise, avoiding eating heavy meals and things. So the weight side of things need to be looked at. If they're overweight, then what are they doing in terms of losing weight? Are they doing anything? Are they not doing anything? Would they like to get some help? Maybe a dietitian referral, maybe linking them to some weight loss programs, such as green prescription, etc. And some other hygiene tips like not having any caffeine, at least 4 to 6 hours before bedtime, preferably avoiding any alcohol if they can, not watching TV or having a TV in their bedroom. Just some basic stuff. There's loads and loads of stuff out there on the internet about sleep hygiene. And also drowsy driving. The main things here is if somebody is tired, they are sleepy, they tell you that they fall asleep driving every time they are in their car, they should not be driving. And the GPs are very good. They usually will say you're not allowed to drive unless you've been assessed by the sleep clinic. For somebody who continues to have the problem with tiredness and sleepiness, and they are on treatment, they're getting good treatment, we usually do recommend that they stop and they rest. If they're feeling too tired, too sleepy, they should pull over, have a little bit of a nap, as long as it's safe on the side of the road, and then continue their driving. They can also try switching their drivers and just basically being safe with their driving, because if you fall asleep driving and you end up going to the courts, they can stop you from driving and remove your driver's license. And you don't really want the hassle of all of that. So driving tips and giving it to your patient would be a good idea. And I think I've got about 8 or 7 something minutes left. So I thought maybe I'll leave that for question time.
That's great, Shyama. Thank you very much. We've got about 3 questions already, and I'd like to think that there'll be some more coming through. We've been asked in the diagram on the page, which is now passed, where you were showing the CPAP machine covering the nasal airways only. Is that correct? You know, you had that slide with the three pictures.
That one up on the top.
No, I think it was. Yes, it probably was that one. Yeah. Yeah. And so it's just over the nose. And so the question was, is that correct?
It is correct. There's lots of different nasal interfaces that are available in the sleep clinics. So there's one that covers only the nose. So it covers the bridge of your nose down to just underneath the nose. There's one that covers the bridge of the nose and covers the mouth as well. So if patients say that they are nose breathers only, and they're quite adamant that they are nose breathers, then the nose mask will be given to them because they will be able to keep their mouth closed. And if they sleep on their side, even if they open their mouth a little bit, it shouldn't cause them too many problems. If they come back to us and say, I actually opened my mouth in the night, or if they tell us at the beginning that they breathe through the nose and the mouth, or if they have any nasal issues, like blocked sinuses or broken nose or, deviated septum, any of that stuff, they get given a full mask, which is covering from the nose of the bridge all the way down to just below the upper lip. That's the second type of mask. Now, all of the masks have got advantages and disadvantages. If somebody has a big mask on their face, they might be claustrophobic and they might say, oh, I actually can't use the machine because I'm claustrophobic. This is too big and it's too bulky and it just makes me feel suffocated. Then for some of those sorts of people, we also have a nasal pillow mask, and it just sits underneath the nose here. And it might have a little tiny band that just goes up here on the top, or it could be just a tiny band that goes up here and then up here. So that's a very small mask. It's called a nasal pillow mask, and then the nose mask, and then the full face mask. Those are the three different types we have. There's also a oral mask which just covers the nose, and the nose is open. That mask is not a very common mask. Majority of those people who use it are previous divers who are used to such masks, and so they would be using it. We only order maybe 2 or 3 of them once every so many months because they're not so common.
Cool, thank you. Now, can you please show a couple of slides again? We've got a request for you to show the slide which talks about differential diagnoses. Can you show that one again, please? Yeah. So if you want to take a screenshot of that, of course, anybody that's watching, you can do that. The other slide that was requested, let me bring it up, was please can you show the sleepy driver screen again, please? That's the one, I think. So once again, if there's useful information on there and you want to take a screenshot, please do. Shyama, you don't mention cannabis there. You talk about alcohol and sedative medications. Do you advise people, given how much use of cannabis there is around?
If they have alcohol on board, they shouldn't be driving anyway.
I know, but you mentioned the alcohol, but not the cannabis. I just wondered.
We do ask them about drugs in clinic, asking them if they take any other illicit drugs, which could also affect their treatment side of things, but it could also make their apneas and hypopneas even worse in clinic. Majority of never actually admit that they do anything like that. It would be an occasional marijuana, but not an everyday thing. But sedative medications, it's basically where some people have like a cold or a cough and they've had lots of something like Lintus, and they are sleepy and they are tired and they try and drive back home. And before they know it, they've actually fallen asleep just outside of their home somewhere. So they thought they were going to be able to make it home, but they just fall asleep somewhere along the line and they've hit into a car or tree or something like that, and they've ended up coming into hospital. These are some of the common sense sort of stuff that they should not be doing. Like if they've had a cough medicine that is making them drowsy, or even otherwise, if they've finished a night shift, you would be amazed at how many nurses actually hit the doctor's cars in the car parks when they're finishing their night shift.
Yeah.
But they're common things. So I think when we're talking about sedative medications, etc., it's just being aware that some of these medications actually do have that sedating effect on them. And then trying not to, drive. If they know that they're feeling tired, they know they're feeling sleepy, they should not even attempt to drive.
Sure. I've got quite a few questions here. I hope you got a little bit of time up your sleeve. Where can we access parts and get machines serviced is one question. That's from Bronwyn. I'm not quite sure where Bronwyn is in the country.
So with counties, we used to service our machines before Now, when I talk about servicing, we obviously, people in the sleep clinic, we are not engineers and we're not technicians of any sort. So we used to take the machines from the patients and then give them a machine that has been returned from Biomed after having the servicing and everything done to them. So they all used to be recycled machines taken from one patient and then being given to another. But with this whole COVID thing, we don't actually want to take the risk of servicing anybody's machine. And I think that has been the rule for Auckland Hospital and other places, from my understanding, for quite a long time, even before COVID, that they would give you a brand new machine, and all new machines are guaranteed to not need servicing for at least 3 years minimum. So anyone who gets given a machine, their machine should be in good working condition for up to 3 years without having servicing done to it. There's no actual internal parts in any of these machines that need to be serviced. So it's generally just a quick cleaner check, just like a toaster at home. You check whether there's any wires sticking out or whatever. If they are, then you obviously wouldn't use it. But if you have filters, and all of these machines have filters on the back, if they're looking quite yucky, you can just take them out and give it a bit of a hand wash, dry them and put them back in the machine while you have contacted the sleep clinic to probably give you some. Now, with the parts replacement issue, some sleep clinics will give you parts for free and some sleep clinics will not. So say, for example, if it's the Auckland DHB sleep service, they will not give you parts for free. You have to go and buy your parts. For Counties Manukau, we will give you parts as long as you're not breaking them too often.
Sure.
So you have to find out wherever you are and what the policies are with your sleep service.
So Bronwyn's come back, she's in Tauranga, so that's been really helpful, I should think, for Bronwyn. Now, Rosanna says she actually has sleep apnea, and she says that she has difficulty in cleaning the tank. Have you got any tips for cleaning the tank?
In the olden days, we used to say soak it in a third of vinegar and a third of lukewarm water and leave it there for a couple of hours maybe while it gets cleaned. If it's already got mold growing, then you really cannot get rid of that mold even after soaking it in vinegar. You can try some Janola, but most people don't like the smell of Janola afterwards because it stays in the silicone for a while, and it can sometimes make somebody's asthma worse. So it's not recommended that you use something like that. Some people do, and it's completely fine. If you find that it's gone brown in color, it could be just where you live and the water supply that you have. So some of the really rural sort of places, they have the water quality is not that great. And so you can have the brown color coming onto your bowl and everything. As long as you can clean it with soap and a dishwashing liquid, just like you clean your lunchbox at home. Just try and give it a clean like that, at least once every week minimum. And as I said before, fill it up fresh with water every night and empty it the next morning, just so it can dry out for the day and it doesn't have that slimy residue building up on there. But if it's looking too bad, then you might actually need to get it replaced.
Cool, thank you very much. Question here, why is TV in the bedroom considered poor sleep hygiene?
Because when you watch anything electronic, it kind of wakes up your brain. So if you look at kids when they play video games, their mind becomes very active. And same for when you watch like a horror movie, you're so into the movie that you kind of jump up and down throughout the whole movie. And your brain gets quite active. So when you go into sleep and you go into bed, you take a long time to actually wind down and fall asleep. So anything that is electronic with the bright light hitting your eye, you actually don't get such a good night's sleep. Your sleep latency is a lot longer than what you might get if you were not watching TV. So generally one of the things in the previous slide that we have is sleep schedule and keeping your bedroom dark. If you've got a TV in your room, that's bright light coming in and it may not make you feel sleepy. Some people do fall asleep because the noise makes them fall asleep. The noise makes them feel relaxed. And so we say to them, you can have a TV in your room. You can listen to the TV, but you don't necessarily have to watch the TV. And perhaps that would be one way to deal with it.
Okay, thank you very much. A question here from Nelson. The threshold for publicly funded sleep study in Nelson is an ESS of more than 12. For patients who score less than 12 and cannot afford private sleep study, is it worth them buying an MAS or such like? And did you say Harvey Norman sells them?
Every sleep service has their own criteria. We, at the moment, don't have any such criteria. Like if the patient says, I'm tired or sleepy, even with an Epworth Sleepiness score of 5 or 6, we would still give them a basic overnight sleep study test to take home, because Epworth Sleepiness scores are subjective. And sometimes people are tired, they are sleepy, but they do not see themselves as being tired or sleepy because they've been like that for such a long time that they think it's normal for them to actually be tired or be sleepy or doze off to sleep after lunch at work. And so the score would be quite low. And I've come across multiple people who have 5 or 6 on their scoring for Epworth Sleepiness score, but on their sleep study test, they come up to have really severe sleep apnea. So it's important, I think, if you've got such a criteria for seeing people in your clinic, some of the basic stuff could be done, like sleep hygiene information pamphlets. As we give them out as well, we give them sleep hygiene pamphlets, drowsy driving pamphlet. We give them just an explanation of sleep apnea and some of the alternate treatments that they can do, including the Mandela advancement splint and weight loss information. The Mandela advancement splints work for mild sleep apnea patients well. And yes, Harvey Norman does sell them. Noel Leeming also sells them. You just have to hop on Google and say, a snore device, and it'll give you multiple places where you can buy them from. There's a website as well, I think, a snore, they sell snore guards. And I think that's directly from the website itself. Not quite sure, don't quote me on that. But just type in Google snoring devices or snore guard, and you will have a whole lot of it come back to you with where they are being sold.
Oh, thank you. Now, I've just got a couple more requests to see the slides again. Have you got time for that, Shyama?
Yes, sir.
That's the one. So, Rosanna, take a screenshot of that one. And the second request was the slide which talks about nurse management. There you go. Another opportunity to do a screenshot. Thank you so much, Shyama. You've had a lot of comments via chat just saying how really, really helpful this has been. Information that people didn't know about before. And thank you for a fabulous presentation. So, it's obviously been very well received. Thank you very much, everybody.